Ladies and gentlemen, I'm excited to be here with you virtually today. However, I would love to be in person next time. My name is Lowell Kabnick, and in the next minutes or so, I'll bring you some exciting news regarding BD advances and innovations in the treatment of varicose veins. Venclose, or the new improved radiofrequency saphenous ablation device. And at the end of my presentation, a hint of what's to come. These are my disclosures. So let's start off with the history of RF ablation. I performed my first great saphenous vein radiofrequency ablation in May of 1999. This was not segmental, but a pullback. Segmental ablation was developed in 2006 with closure fast. The technology stayed the same until 2016 when Venclose was introduced, a radiofrequency ablative truncal device, and this was followed by the Maven Perforator device. So let's look at Venclose. So the generator is really a simple setup, plug and play. The advantages of the Venclose catheter are that it's smaller, it's 6 French versus 7 French. It's better cosmetically, 10 centimeters ablating device versus 7 centimeters, so it's faster. It's got a curved tip which provides maneuverability within the vein. Of importance is 2 different ablating devices within the same catheter, one that's 10 centimeters and one that's 2.5 centimeters. This obviously would reduce the inventory costs and the potential of needing to use 2 catheters. So let's look at case number 1, a great saphenous vein ablation. This is a 59-year-old female who's symptomatic with varicose veins with a VCSS score of 5. Patient has been classified clinically as a C3. On lower extremity physical examination, there are varicosities below her knee in the zone of the great saphenous vein influence. Her pulses are present and 2+ equal. If you look at the venous map here, it shows that the great saphenous vein is competent at the saphofemoral junction and incompetent from the great saphenous vein from the proximal thigh to the proximal calf. It's positive for reflux, and the great saphenous vein measured at the mid-thigh 5.6 millimeters. This is a panoramic view of the case showing antegrade flow at the proximal thigh and reflux below. Next set of slides will be a series of step-by-step. So the first picture shows the introduction of local anesthesia. Next, I'm demonstrating access using a 21 gauge needle. In this slide, looking at the ultrasound and the arrow, I've gained access by the needle into the great saphenous vein in a short access procedure. After access, disengage the 21 gauge needle and an 018 wire is inserted. The 018 wire is then back filled into the 6 French sheath, and prior to inserting the sheath, local anesthesia is infiltrated in the area, which reduces any of the discomfort secondary to the sheath. As you can see now, the sheath is in place with the 018 wire and the introducer. The next step would be to remove the introducer / dilator as well as the 018 wire. After this step, the Venclose catheter is introduced into the 6 French sheath and parked 2.5 to 2 centimeters below the saphofemoral junction. Using local anesthesia tumescent, the infiltration is done the same way as all of the thermal ablative devices. Once the tumescent anesthesia has been administered and checked by duplex to make sure it's continuous, the ablation is started. I recommend that if the vessel is less than 10 millimeters, that you do 2 cycles at the junctional level, followed by 1 cycle. Then if it's 10 millimeters to 17.9 millimeters, 3 cycles, followed by 2 cycles thereafter. And if it's 18 millimeters or larger, then 3 cycles, followed by 3 cycles thereafter. A postoperative duplex is performed, and in this duplex ultrasound, you can see that the great saphenous vein has no flow. So let's look at continued advancement in radiofrequency ablation. Next, I would like to talk about the new RF perforator ablation device called the Maven. It's a new treatment option for treating incompetent perforator veins. It has a 0.5 centimeter resistive heating coil, which is different than the Venclose, being 10 centimeters or 2.5 centimeters. It also has an inert tip being approximately 3 millimeters. The interesting part of this is that it heats to 130 degrees centigrade with 20-second cycles. The catheter is flexible and 6 French and accommodates a 0.025 wire. In this case, which I'm going to demonstrate, was particularly difficult in trying to restore flow in the deep venous system secondary to a patient that had a recalcitrant ulcer. In this duplex ultrasound, you can see that there's a long feeding segment to the deep venous system here, and this is the measurement of the incompetent perforator. And also you can see where the fascial area is and the posterior tibial vessel. If you look at screen right, you can see that there is obvious reflux. On this slide, you'll see a series of steps introducing the procedure for the Maven perforator. Of note is the utilization of an angiocath or a 6 French introducer sheath. We start off with local anesthesia over the area of the intended access site for the perforator. Once that has been achieved, the angiocath is being seen introduced here and into the perforator shown by duplex. Once that is performed and you have visualization and backflow, the Maven catheter is inserted. So we park our catheter just below the fascia. We treat that with 6 cycles, and then we move the catheter back to just above the fascia and treat with another 6 cycles, and then we treat successively out, moving approximately 0.5 centimeter and delivering 4 cycles. And here is the postoperative duplex showing closure of the perforator. Ladies and gentlemen, I'd like to thank you and leave you with this message. I'm really excited about this new innovation and technology.